Hello, everyone. My name is Elena Venegas. I am a registered nurse and a nursing student with Midwestern State University for my Bachelor's of Science in Nursing. I am going to be presenting to you today my capstone project required for graduation, birth unassisted versus overmanaged. Um, let's get into my objectives. The objectives for my capstone project for you guys are going to be that you can identify the challenges and problems, opportunities that inspired this proposed capstone project, describe the important issues or conditions that exist in leading to the proposal, that you can identify the stakeholders and discuss how the proposal will impact each individual or group, and identify possible limitations and barriers to evaluating those outcomes. Also, that you can identify how the capstone proposal could be implemented, describe the actual or potential impact this proposal would have on the nursing and healthcare community, identify the outcomes that are expected if the proposed project were to be implemented, and identify opportunities for this information to be presented in a setting beyond the classroom. We'll get into my rationale and purpose behind this capstone project. I am a labor and delivery nurse, so for me, this was a little personal. The goal of this proposal is to determine if the use of continual fetal monitoring causes more harm than good when monitoring low-risk maternal patients. In my research, my literature review, it shows that the use of continual fetal monitoring can lead to a prolonged second stage of labor and an increase in cesarean deliveries, also an increase in maternal labor interventions, and an increase in newborns needing neonatal intensive care services after delivery. So, those are some of the reasons why I chose to look further into using intermittent fetal monitoring as opposed to using continual fetal monitoring and the impact that has on mothers and their delivery birth process. Um, we'll get into background and significance. Um, the fetal surveillance was introduced, of course, to help detect fetal hypoxia during labor. However, despite the advances in fetal surveillance, it has failed to reduce the number of emergent cesarean deliveries. And actually, we have seen an increase in emergent cesarean deliveries and just cesarean deliveries overall. Intermittent fetal monitoring is shown to provide the same level of care as continuous fetal monitoring and has a much lower incidence of emergent cesarean delivery without a negative increase in an increase in negative outcomes. So basically what that means is using intermittent fetal monitoring for low risk mothers is actually beneficial because it helps decrease the risk that they have for cesarean delivery versus if we monitor them continuously, this increases their risk for having to have a cesarean delivery due to fetal tracings that may or may not show need for a cesarean delivery just because we are monitoring mother continuously instead of intermittently. Let's see. Next, we have our problem statement. My problem statement is in hospital-based labor and delivery setting, caring for low-risk mothers. How does implementation of intermittent fetal monitoring compare to continual fetal monitoring and affect the patient's progression of labor and desired vaginal birth as reported by hospital delivery records and HCAPS? During my literature review, I did notice that the use of continual fetal monitoring in comparison to intermittent fetal monitoring, it does help reduce the need for cesarean delivery. So intermittent fetal monitoring helps to reduce the risk for cesarean delivery. There is an increased number of cesarean deliveries in high income countries where advanced fetal monitoring is common practice. Interventions such as continuous fetal monitoring in the first stage of labor lead to an increase in the need for intervention during the second stage of labor. There is a 99% false positive rate of detecting hypoxic ischemia, encephalopathy, brain cerebral palsy, and impending fetal death during labor, and this leads to up to a 20% increased rate of cesarean delivery. So, while doing my literature review, I noticed that Interventions associated with continuous fetal monitoring include oxytocin induction, so augmentation of the mother's labor with oxytocin due to reasons such as on the monitor, her contractions are not showing strong enough, not showing that they're happening frequently enough. So the doctors decide to use oxytocin to help augment those contractions and speed up the labor. Continual fetal monitoring also restricts free movement. A lot of mamas, when they're hooked up to the continual fetal monitor, they can't really move around freely because they're constantly attached to these monitors. And most hospitals do not have the fancy wireless monitors, so they're essentially tethered to a machine, and we have to keep baby on the monitor. So it doesn't allow for the mother to move in positions that are comfortable and more conducive to birth. So a lot of mothers feel they have to lay flat on their back and perfectly still so that baby's on the monitor, and this can hinder labor. Also, another intervention is amniotomy, which is breaking their bag of water. This at times can prolong that second stage of labor. Also, the second stage of labor is shown to be longer in those mothers that we perform these interventions during their first stage of labor. So, the rate of cesarean section increases with a longer labor. So if we are implementing interventions to extend that second stage of labor, such as continual fetal monitoring and all the other interventions that come along after we have a mom on continuous fetal monitoring, we are in essence increasing her risk for a cesarean section. And also, we do increase the risk for the babies to need neonatal intensive care support. All of our mothers in my facility that receive a cesarean section have to have a pediatrician available at delivery, whereas in vaginal births, we don't need a pediatrician or any other neonatal intensive care support at delivery necessarily, unless there is a prior issue with the pregnancy. But during vaginal delivery, the nurses are present at delivery and the doctor, and that's it. We don't have any support for baby. But at our hospital, every cesarean delivery has to have a pediatric or a neonatal intensive care provider present. That is because cesarean deliveries are harder on baby and harder on mom. So it's increasing that risk to baby and mother. And it's determined that interventions during that first stage of labor negatively affect the delivery process, and they negatively affect mom and baby and lead to the need for more intervention in the second stage and lead to the higher rate of cesarean section. Um, so, in my review, again, let's go to the next slide. Um, More of the literature shows that we should consider the mother's preference in her and her clinical presentation when we're choosing what type of monitoring she should receive. In my facility, they do continual fetal monitoring on everyone, and it should be a choice between intermittent and continual based off of the mother's situation. And some women also may choose to deliver at home and avoid the hospital setting completely due to previous bad experiences. And also, I learned that a part of the WHO's World Patient Safety Goals in 2021 is to reduce the unnecessary and harmful practices to women and newborns during childbirth. This includes unnecessary interventions such as continual fetal monitoring that is not needed in most cases. So, for mamas that don't need continual fetal monitoring, it is better for them to have intermittent fetal monitoring to lower the risk of cesarean delivery and lower the risk of interventions being implemented during her labor. We Compared to other types of fetal surveillance, intermittent monitoring reduces the risk of cesarean deliveries and labor, and it does not increase adverse neonatal or maternal outcomes. So there have been many advances in fetal monitoring, but despite all of those advances in research, the overall effectiveness of measures to improve neonatal outcomes, it remains debatable because the outcomes are holding steady. So all of the advances and all of this continual fetal monitoring is not necessarily improving the outcomes of babies. We're kind of steady when we used intermittent auscultation or even the fetoscope or a stethoscope to listen to baby's heart rate. Not necessarily the advances in having a mom on continual fetal monitoring hasn't really increased babies' um, outcomes. It's shown to hold steady. So the use of intermittent fetal monitoring could be a better choice versus continual fetal monitoring for moms that are not high risk. So for um, implementation of this project could be creating a policy that outlines specific orders for intermittent fetal monitoring for all low risk mothers. We could create the need, it would also create the need for more nursing staff, as intermittent fetal monitoring is often requires a 1-to-1 nurse ratio. Education regarding the intermittent fetal monitoring will need to be provided to the patient and family, as there may be some apprehension. Education of hospital staff will need to be very detailed and a clear understanding of the new orders and when we need to change those orders from intermittent fetal monitoring to continual fetal monitoring. And some barriers could be physician pushback and nurse pushback as well, because, like I said, a it will create a higher workload for nurses because they'll need to be 1-to-1 for intermittent fetal monitoring. And physicians, and sometimes mothers as well, want to have their patients on the monitor 24/7. That way they don't miss anything and they are constantly looking at the baby, which in most cases is not really necessary. But evaluation of this project, we expect to see an increased number of uncomplicated vaginal deliveries and a decrease in cesarean deliveries and other medical interventions. Evaluation of the data collected from hospital delivery reports and HCAPs will provide the information needed to show that intermittent fetal monitoring provides the same level of care and will also help reduce the maternal interventions and labor complications, such as cesarean delivery, that puts moms at a greater risk for complications later on in their postpartum period. Um, the dissemination, we could use organizations such as AWAN that could provide credit for continuing education, and this project could qualify for assistance in developing education and in-services for staff. The findings could be published, and this could also help other hospitals in search of evidence-based practice articles regarding the benefits of intermittent fetal monitoring. And during the project interview, it was found that many nurses are interested in intermittent fetal monitoring and its benefits and would be willing to spend the extra time with patients and the learning of new protocols if it meant fewer medical interventions and more spontaneous deliveries for their mothers. Um, so when speaking to my interview with my Capstone expert, which was a registered nurse who had been a registered nurse at my facility for a while, she said that one of her main concerns was the use of continual fetal monitoring and how that continual fetal monitoring leads into unnecessary cesarean sections due to doctors being unwilling to do other interventions when they see a fetus that they determine to be in distress based off of only their fetal monitoring strip, which in opinion would be use other factors as along with the strip to determine, but usually they look at the strip and determine solely based off of the strip. So, in summary, this project hopes to show the use of continual fetal monitoring for every patient is outdated. Evidence-based practice now shows that intermittent fetal monitoring is a better, safer, and more practical approach to the birthing process. Research shows that the use of continual fetal monitoring can, in fact, be counterintuitive and has a high risk of causing medical interventions that are, in fact, unnecessary and lead to an over 20% higher chance of cesarean section, and that it is 99% false positive rate in detecting fetal distress. So again, I hope that if this project would be implemented, we could reduce the risk of unnecessary C-sections and help our mamas have more vaginal deliveries. Thank you so much for listening to my presentation. My references will be attached. Thank you.